I would like to welcome you as we learn and discuss Lean healthcare components and the key strategies essential for success. I would like to review just a few housekeeping tips before we get started. Please note the audio is available through your computer speakers, and it's not necessary to call in. Questions can be submitted anytime using the Q&A window on the right side of your screen, and at the end of the presentation, we will open up the discussion for question and answers. We'll also follow up and send you a copy of the slide presentation in a few days. It's a pleasure to introduce today's guest speakers. Is a senior fellow with the Lean Enterprise Institute and author of the book Lean Hospitals, Improving Quality, Patient Safety, and Employee Satisfaction. He is the founder and lead contributor of leanblog.org that started in January 2005. More experienced consultant and change agent with a background in industrial and mechanical engineering and graduated with an MBA from MIT. Mark has worked for General Motors, Dell, and Honeywell. Since August 2005, Mark has worked in the Lean healthcare world, where he has coached Lean teams at client sites in North America and the UK, including medical laboratories and hospitals. Mark's mission is to apply Lean and Toyota production system principles to help build strong organizations to improve quality of care and patient safety, improve the customer-patient experience, and to help the development of employees. Curtis will also be joining us today. Sean is the Director of Product Development for FormFast. 12 years of experience in the software industry, creating and managing software products for healthcare, financial services, logistics, government, and manufacturing markets. At this, I would like to turn it over to Mr. Mark Graven.
Laura, thank you for the introduction, and thank you to FormFast for hosting me today, and thank you for everybody who is attending. We probably have attendees from all over the world, and I think it's fair to say that lean healthcare is indeed a global trend, as we see represented in this map. Now, this is by no means a complete map. It's pretty North American biased, but this shows documented instances of healthcare organizations using lean, documented news stories, articles, or job postings. And I think it's a positive trend in terms of reducing waiting times, improving quality and patient safety, and improving the cost of care around the world. Some points for today that we could talk about in an overview of lean, but some key points to touch on is that lean is transferable across industries. Lean is not an anti-technology. It is indeed an organizational strategy, including for healthcare organizations. It's not just cost-cutting. That literature and lean methods and management ideas can help prevent errors, and that lean engages everybody in process improvement. A bit of background for those who are new to lean. Credit is certainly due to Toyota and their Toyota production system, and also what's known as their Toyota product development system and their Toyota way management principles. Now, Toyota didn't completely invent the mindset and methods of lean all alone. They learned, and they give credit to people like Henry Ford, W. Edwards Deming, and many others around the world. So it really is just a quote-unquote Japanese management method, even though it is, of course, associated most closely with Toyota in the auto industry. The term lean, which I always like to remind people is not an acronym. Sometimes you see lean in all capitals as if it is an acronym. The word didn't come from Toyota originally. It was coined by a research team at MIT that studied the auto industry in the late 80s. This is a study that showed that lean methods could be used. First it showed that it could be used in auto plants across different cultures and different countries. And the follow-up book, Lean Thinking, lean concepts could be transferable across different types of industries. And one thing is, I think, worth pointing out about lean or the Toyota way management philosophy. Management philosophy is arguably much more important than the tools. What Toki Ono, one of the founders of the Toyota production system, called, quote, the equally important pillars of TPS, that these are equally important. So the idea, most organizations don't be distasteful. They jump at the chance, the idea of eliminating waste and continuously improving. The other pillar, which is often ignored at the peril of organizations, is maybe this kind of high-minded notion of respect for people, or what Toyota originally called respect for humanity. It includes employees, customers, suppliers, the outside community. We could probably spend 30 minutes alone on this topic of respect for people, but if you're implementing ideas without respect for people, you're going to run into problems. For example, outside experts come in and run roughshod over people, dictate lean changes to them. That's not going to be as effective or sustainable as avoiding that old traditional top-down approach to implementing anything new. Lean, the Toyota approach inherently involves people at all levels of the organization, and we involve improving their own work and working together to improve their own systems. So there should be an equal balance between these two approaches. I'll touch on Six Sigma for a minute, because we're often asked what the combination or distinction between Lean and Six Sigma would be. And I'm the first to admit I'm not the world's Sigma expert. I don't have a black belt or any such thing. But Six Sigma can be very compatible with Lean. As with Lean, Six Sigma is often focused on not just improving quality, but improving business results. And either methodology, Lean or Six Sigma, can get off track if cost cutting is the only goal. Sigma, popularized by GE, comes from Motorola. There's a lot of shared roots from TM and some ideas from Dr. Deming. Lean has its PDCA cycle. Six Sigma has the DMAIC cycle. And I think one difference to point out is that Lean tends not to have the formal belt structures that you have within Six Sigma. And in this slide titled, I've seen demonstrated and believe that Lean and Six Sigma can work together well. I think that's the way to look at it, is Lean and Six Sigma, as opposed to a consolidated methodology that you might call Lean Sigma or Lean Six Sigma. But to be clear, I'm not being anti-Six Sigma. I think Lean and Six Sigma do work well together. It's maybe interesting to think it doesn't use Six Sigma. They use some of the basic quality control tools, such as prayer charts and other things that are also incorporated with Lean. From my experience, Lean is a broader culture and management system than Six Sigma tends to be. And I think there's a common straw man that's laid out there that's correct. You sometimes hear people say that, well, you need Lean for efficiency and you need Six Sigma for quality. And it's part of the core definition of Lean and TPS that it's about flow and quality. And arguably, Lean is primarily a quality improvement system where improving quality and flow very much go hand in hand. A bit more detail around the Toyota structure, and a really good reference on this is the book The Toyota Way by Professor Jeffrey Leiker. To move beyond the tools of Lean, there's 4 ideas that translate really well into any setting. First off is to focus on the long-term philosophy, as Dr. Deming always taught. That was clearly a lesson that Toyota learned from them. The second is to focus on the process, and for example, not blaming individuals or beating up on people for poor results after the fact. Results matter, but in the Lean philosophy, you get them by managing a process and by managing people. To add value to the organization, you develop your people. It's often said that in the Toyota approach, their job is to develop people before developing cars, and that this thinking process, helping people improve their problem solving and improvement helps lead to continually solving the root problems. That creates organizational learning and is good for the organization and for everybody involved. Of the 14 principles of the Toyota Way, I want to focus on number 8. And it says here, use only reliable, thoroughly tested technology that serves your people in your processes. Sometimes gets accused of being a bunch of Luddites, that they're anti-technology. Well, they do certainly use software, but their factories aren't run using some of the traditional computerized plant methods that traditional manufacturers use. Toyota uses computers where appropriate. I think they view technology as not being a silver bullet, but technology can fit with the right processes. So, for example, in a hospital, you can put on each patient's wrist and barcodes on each medication. But without the right philosophy and management system, you're still likely to have medical errors. Without the right management system and environment, nurses and pharmacists might have too much waste to deal with during their day. So they end up overworked and overstressed. And without the proper help, the right staffing levels, the ability to reduce waste to free up time for patient care, people are often pressured into cutting corners. They print out extra barcodes, for example, that help circumvent the well-intended system. So there's many examples within healthcare where technology alone, out of context of the right culture and management system, aren't going to be as effective as when it's combined with this Toyota or Lean mindset. So natural question, we talk about using Lean in healthcare. How in the world is an operating room like an assembly line? And it's a question people should be asking in healthcare. We're not blindly transferring tools and methods. Now, some tools from manufacturing can indeed solve real problems in healthcare, critical problems. But the management system and the culture that I think is most transferable and most important. So we're not doing anything like putting the operating room table on a very slowly moving conveyor belt. That would be crazy. That would be an inappropriate application of something we might see in a factory. I'd almost that factory workers in a lean factory would have better systems to ensure that they can do high quality work. And if they face problems during the day, that they can get an immediate response from a supervisor who can help them solve the problem and prevent it from occurring again. Healthcare, unfortunately, teams and individuals are often left to fend for themselves when they face problems, and patients can suffer as a result, unfortunately. So as you see here, people often refer to Lean as being an iceberg, that what you can see above the surface of the water are things, Lean tools like 5S, A3 reports, value stream maps, important stuff. But below the surface of the water are the things like culture, management system, and philosophy. Hard to see, but very important. So an example of ThedaCare in Wisconsin, how they've adapted Lean to a hospital setting, how they're using Lean as a strategy, not just a bunch of tools. So first, ThedaCare is on the patients first, not the hospital's needs or the staff's convenience. So designing care around the patients. They're bringing value for the patient and getting rid of everything else. We would call that waste, or they're eliminating at least as much waste as they can. And thirdly, they're minimizing time to treatment and through the course of treatment. Lean is a very time-based methodology. One way that this is very different from kind of traditional cost cutting is that Lean focuses on minimizing time through a system by eliminating preventable delays, by eliminating waiting time. And with this compression of time tends to follow quality improvement and cost reduction. So we're not focusing primarily on cost, but yet we're getting a lot of improvement in that area as an end result of the process improvement. And you look at examples of organizations using Lean as a core part of their strategy. Again, you have ThedaCare. They're using a full-blown management methodology called strategy deployment, which helps align people at the levels of the organization. Virginia Mason in Seattle, you see their book pictured here, Transforming Healthcare. They've very much made it a part of their strategy, and they have patient improvements, including more time at the bedside for nurses by eliminating waste, faster cancer treatment, and this means eliminating delays and waiting time for patients. Denver, a public safety net hospital in Denver, Colorado, has documented savings of $54 million over 4 years, and they've used those savings, as their CEO has commented, to avoid layoffs. Very different than traditional hospital cost cutting that might involve a lot of layoffs. Children's Hospital has avoided $180 million in capital spending by using Lean methods to improve processes and space utilization to increase capacity for patient care without going and building bigger facilities or new facilities. So there's a lot of benefits from a financial standpoint and from a patient care standpoint. ThedaCare, for example, in their Lean-based collaborative care units, has gone for more than 3 years without a medication reconciliation error. Allegheny General Hospital in Pittsburgh, they've central line associated blood infections by 76% in their ICUs, and deaths are down 95%. So again, there's very much hand-in-hand relationship between quality and patient safety improvements and financial impact. Mason, and this is published in their book, you see their illustration of hospital strategy, very much has Lean, or what's called the Virginia Mason production system, at its core, a foundation to being patient-focused, to being a quality leader through Lean and other strategies, focusing on people, quality, service, and innovation, not the simple elimination of waste. The ThedaCare is a result. So they're what they call true north from their strategic deployment method, focuses on customer patient satisfaction, safety and quality, their people, and financial stewardship. And again, that financial stewardship piece is an end result of all the other improvements. It's not the first and primary thing. So care has cost savings that have gone to the bottom line. But maybe more importantly, care is improved. 89% of stroke patients now get a CT scan within 25 minutes of arrival, up from 51%. They have lower mortality after cardiac bypass surgery. Babies are being born preterm because they're applying Lean principles to be proactive in managing preterm care, and they have higher staff satisfaction. It comes as a result of having really kind of balanced goals, putting the customer and the patient at the middle, focusing on quality, engagement, and business results. It's an example of how when Lean is done properly and with the right mindset, it's really for everybody, for all stakeholders in the process. If we were to just copy a few random Lean tools, or if we only focus on cost, things are likely to not get much better. Core Lean concepts is this idea of standardized work. It's a common problem around the world when people look at the cause of quality problems, patient safety problems, things that are frustrating to staff. I saw a presentation from a group in Puerto Rico. Speak really any Spanish when they put up on their slide, proceso no estandarizado. Well, that jumps out, that means that common problem that the process is not standardized. We see this in English, in Dutch, and in Swedish at conferences and hospitals I've visited around the world. Standardized work in the Lean mindset does not mean robotic or unthinking. Standardization can and is demonstrated to improve the quality of patient care in a number of settings. And without Lean, we often have problems, as documented in Vegas Sun, problems that occur from hospitals not following procedures and what you might call standardized work. What about the culture and the management system and the environment as opposed to blaming people? Why are you doing colonoscopies in street clothes instead of scrubs? Why are patients with C. diff not being properly isolated? One shocking example of a patient catching fire in the OR where they draped the patient before the flammable alcohol solution had dried. Further violated procedures by not calling the fire department. So we have a lot of problems in healthcare. It's not that people don't know what to do. The environment and the system and the culture often gets in the way, doesn't allow people to do the thing. So a core lesson, rather than pointing fingers at individuals, is to ask why. Why are people not following the process? And as we illustrated here, I don't know the exact origins of this diagram, but you see this road with a gate. And it's clear that people don't understand why using that gate is important, because people are just driving around it through the snow. People following the process, is it a training and communication issue? Or do people in this picture or in healthcare time to do things the right way because there's too much waste getting in the way? Do supply chain issues, for example, prevent people from having what they need to get their job done? Workarounds or forcing corner cutting? We have to ask why. And there are Lean tools and management methods and mindsets that can help address situations like this. It's not a simple tool. It's a very core cultural issue. So at ThedaCare, their care of code STEMI patients coming to the emergency room. As they stated in 2002, they did not have a clear standardized response to heart attacks. Now, as people often say, each patient is unique, but that doesn't mean we have to reinvent care every single time a patient arrives. There are many types of care that can be standardized, but again, that doesn't mean we want people to shut their brain off at the door. Now, care in their team, their clinicians develop their own standardized work, and I think that's a key point with Lean, is that you don't force standardized work at people. Clinicians develop the standard work that you see here, and it's hanging in each room in the emergency room. So they've been asking, why were things always done this way? What can we do to change the sequence to get the patient's EKG done without delay and to get the patient to the cath lab when they need to be in a more timely way? In instances where clinicians have developed standardized work, and I think this is a good practice for anybody in any role, standard work gives guidelines for what should happen unless there's a situation that's unique. I want people to use their critical thinking, and in some cases, groups of surgeons have put together standardized work, and guidelines is that the surgeons, of course, could choose to not follow the standardized work if inappropriate for a certain patient. But there needed to be medical reasoning behind that, not just being somebody waking up and not wanting to follow the standardized work that day. There had to be a good justifiable reason for that, for what was necessary to provide the best patient care. So you see the improvement in the data around ThedaCare's door-to-balloon time. The national guideline, as many of you may know, used to be 120 minutes, and ThedaCare had been hitting that 70% of the time. But now they have 100%. They're that lower 90-minute national target, and they reduced the average time to 37 minutes. So this is not just being faster for faster's sake. This is really leading to dramatically better patient care. As they say at ThedaCare, time is muscle, and this leads to better outcomes for patients when they get that blockage cleared more quickly. Other improvements, and this is peer-reviewed data that was published in Health Affairs and other journals, as well as their book called On the Mend. ThedaCare used a number of lean methods to improve coronary bypass surgical care. And you can see, first off, and most importantly, mortality fell from 12 patients, or about 4% in 2002, to just one patient in 2009. With that, length of stay and cost both decreased about 22%. So another framework is this idea of eliminating waste. We get the 8 types of waste, both in clinical and administrative settings. Types of waste can be found in pretty much healthcare setting in any hospital around the world. So it's important to emphasize this is not what's wrong with a particular hospital, and it's certainly not what's wrong with any individuals. The waste is often systemic, and that's why we need to put teams of people together using lean methods to help identify and eliminate that waste. An example might be what we would call the waste of overprocessing. Work that's unnecessary, or doing work at a quality level that's unnecessary. For example, in healthcare, I've seen in a lot of organizations would be purchasing approvals. You have paperwork that's routed to multiple levels of management. And at one hospital I work with, they discovered that VP always had to sign off on purchasing requests, but the VP had never once rejected a request that had been approved by the director that reported to them. So here's an example of asking, well, why do we need that approval? Why can we eliminate that step? You know, it's a good example of not wanting to automate that waste. If we decide that the VP approval wasn't necessary, we don't want to put in place a solution that just makes it electronic. If we look at examples outside of paperwork and forms, one trend in hospital laboratories had been to install a lot of automation and robotics, as you see pictured here. But in a lot of cases, those hospital labs learned that they were really just automating a bad layout. Hospital's example, they spent $1.5 million on automation, about $125,000 a year to maintain. Now, they reduced headcount. They had productivity improvement. I've seen in a lot of hospital labs, what you end up with many times is slow turnaround time. So they're making productivity improvement in the lab, but at the expense of timely test results and timely care. It's a lot harder to measure the cost of that to the hospital as a whole, which is one example of what's unfortunately sometimes siloed thinking. If you look across the span of the hospital and find a way to reduce turnaround time with automation, we can reduce length of stay in the emergency department, we can accelerate or prevent discharge delays from the hospital. But typically people are organized around their own budgets, and we might make decisions that are locally optimal but not good for the organization as a whole. An example from an organization I used to work for, Washington Hospital Center, got rid of their automation. Did a lean physical layout that grouped the equipment in a different way. It changed staffing patterns, and they started hitting their turnaround time goals much more frequently than they had been with the automation, which helped reduce hospital length of stay and improve hospital care as a whole. So we talk about time and waste and flow. I also want to talk a little bit about quality here. As highlighted in some of the studies from 10 years ago, from IM studies and including to err is human, data is, adverse events occur in about 4% of hospitalizations. 13% of those lead to death, and different studies show more than half of those are preventable. So do the math. Unfortunately, the starting point for most hospitals is that a preventable death occurs in about 1 in 400 hospitalizations. Mid-sized, average-sized hospital, that might mean 1 death per week. And this is, of course, a serious problem and something that we can address through lean methods. I'm a big fan of Dr. Gwande's book, The Checklist Manifesto, because I think philosophically it's very compatible with lean in terms of the idea of people developing their own standards to work and having a management system that helps encourage the ongoing use and ongoing improvement of that method, of that standard work method. We've learned hospital-acquired infections don't have to be taken for granted, that they can be dramatically reduced. The General Hospital Pittsburgh, under the guidance of Dr. Richard Shannon, was using lean and Toyota-based methods, very similar to this checklist approach, to reduce infections by 68% through standardized methods and standardized supplies. And again, he proved also that it was only good for the patient, it was good for the hospital financially by reducing these preventable infections. So thinking in our mindset and our framework here, the focus is on the process or thereof, not the people. We want to stop, as people in hospitals say, the old culture of naming, blaming, and shaming. We need to focus on process. We need to be proactive to prevent patient safety incidents and patient harm and death. Look at the case of a patient at Virginia Mason Medical Center in 2004. Now, Virginia Mason Hospital is using lean. This is something that happened very early in the journey and became something that they learned from and led to a lot of improvement, but I think it's a cautionary tale that hospitals can use to help proactively prevent situations like this. So Mary McClinton did, a topical antiseptic was mistakenly injected into her. Now, part of the problem is that there were identical looking clear liquids in different containers on the tray. And you see in the lower left-hand side of the picture, he's the hospital employee who injected Mrs. McClinton. He said, this was a news story a couple years after this incident, he said, mistakes will happen, he said sadly. We're externally human. And he's absolutely right. If we look at the process and the culture involved here, he knew the same color solutions and the risk of mixing up syringes 2 years before the fatal error occurred, that they had switched from a brown cleaning solution to a clear one. It's the question, is the culture one where somebody knew of a risk but either couldn't speak up or didn't speak up? Why were managers and leaders not aware of the seemingly obvious risk factor? Now, the man involved had actually mentioned the problem to a supervisor 2 months before the fatal incident. So why did we have somebody finally speaking up and not have good, clear, fast, responsive action from leadership? Why do things like that happen? How can we prevent this? I think this is the challenges and a clear lesson of a lean culture would help prevent problems like this, because an environment where leaders are observing work, they're aware of problems, they're talking with their people, and they're creating an environment where people can speak up and raise issues and get a response instead of just being told to be careful. Because being careful just is not enough to ensure quality and patient safety. That's something important from the lean philosophy. So we need to engage people in hospitals in improvement, improving quality, improving processes. This is from a hospital I worked with where the nurse said, I've worked here for 6 years, and this, meaning the lean process, was the first time anyone has asked me what I think about anything. Maybe a bit of hyperbole there, but I think directionally she was probably correct. So culture change isn't just about blame and shame. There's also a huge problem in terms of ignoring and not engaging staff members in improving their processes, improving care for patients. So move beyond kind of a classic traditional suggestion box, if you will, as we see pictured on the left. Worked with before they had lean management methods in place, the suggestion box, and when we went to go open the box to see what the ideas were, they couldn't find the key. This box process was a slow, batchy, failed process. The ideas were basically just rotting away in the suggestion box. So we transitioned to what we might call a visual idea system, and this comes primarily from a book called Creating a Lean Culture by David Mann, where you engage people in daily team huddles. You work together in terms of getting a rapid response from supervisors and leaders. Implement ideas and to follow the PDCA experimental process rapidly instead of just having a monthly or a quarterly review of suggestions, for example, and having managers or directors sitting in the room just saying thumbs up or thumbs down. You want the team implementing and running structured scientific experiments with their processes and their work in the workplace, and that visual idea system is one way of tracking and facilitating that process. So for my work from hospitals, I believe very strongly that it's the employees and the hospital staff members and the clinicians and leaders who have the answers. It's not lean consultants coming in and telling you what to do. It's more importantly and more effectively, it's about teaching lean concepts to these people. See pictured here, laboratory staff members that learn to observe their own work, to observe their own processes, to work with their peers in identifying waste and improving processes. On the right, see hospital staff members working on variations of a new laboratory layout, that this is their layout that they're developing on lean concepts. So as the equation shows here, I think it's the existing knowledge of the process, plus lean concepts, plus giving people time to work on it that leads to Kaizen or continuous improvement. Or as one of the people pictured here said, we're finally being asked what we think about improving their work, both for the patients and creating a better workplace that they're more satisfied to work in. So just a recap in terms of key points before I'll hand things over to Sean, is that we're seeing more and more that lean is indeed transferable across industries, including to healthcare. And this is true when we adapt the management mindsets and philosophy and culture of lean, just picking and choosing lean tools. That lean is not anti-technology, but the lean philosophy tells us to look at using technology in the right way or in the smart way that supports our people and processes, not just automating old wasteful methods. Lean is indeed increasingly an organizational strategy, including organizations like ThedaCare and Virginia Mason. And Lean is more than just cost cutting, that we don't focus primarily on cost. We focus on time, we focus on quality, and cost reduction tends to follow, thankfully. That there's many instances where Lean culture and Lean methods can help us prevent errors through different management methods and mindsets. And that at its best engages everybody in the improvement process. So I want to thank you for listening to my portion of the presentation. I'll hand things over to Sean, and then I believe we'll have Q&A after he's done. Thank you.
And thank you so much for your insight today. We really appreciate that. Since FormFast software has enabled healthcare organizations to achieve significant process improvement across the enterprise, supporting HR, contract management, rogue clinical processes, risk management, and countless other workflows. FormFast is a top-ranked provider of electronic workflow solutions and serves 850 hospitals internationally. FormFast software helps healthcare organizations accelerate their progression from time-consuming manual processes to fully automated workflows. Good morning. Welcome to Sean Curtis, Director of Product Development for FormFast.
Thanks, Mark. That was a great presentation. So my goal today is to follow up with what Mark talked about and bring it down into what FormFast does and the areas that we can affect with our technology and our services and our solutions. One of the things that Mark mentioned was asking why, and this is a great picture that he showed on his slides early on. It's a barrier across the road, but it doesn't seem to be effective. So why is that still there? Why haven't they fixed that? Why haven't they changed that? We've got, ruts in the grass going around it. Why? And that's a good place to start. If you have things in your hospital that you feel like you want to change, you need to change those. That's why those are happening. You want your nurse to spend more time with patients, so ask why. What's keeping them from doing that? That's the place to start. And there are some contributing factors, and this is an example that I learned at the Institute for Healthcare Improvement. A group down in Texas had done a study to improve their documentation and documentation time. These are numbers about why they had to do that. Just to give you the idea of the size of the hospital, 32,000 admissions a year. And then they found that there was 26 forms per patient, and then on a day basis, 25 more forms. And today there was 5 more forms. The overriding factor here is that in a 12-hour shift, over 6 hours were spent on documentation, and the nursing staff handled 2 million forms every year. So that's a huge contributing factor to what they're doing rather than spending time with patients. So that's a good place to start and something to look at. And also, as we go forward, things that we're going to provide and help with those numbers. Yeah, directly clinical, but why exceptions in the coding process that slow down our revenue cycle? So every time a coder can't straight through process a record into your billing system, there's an exception there. They have to maybe find out more information from a physician, learn information about the procedure, or have better documentation. We have processes in place now that help you with this, or your process in that area is causing you problems now. Wait a couple of years until you see ICD-10 go into place, and it's going to be more specific about its coding. The code library goes from 13,000 to 68,000 codes. For example, there's 50 different codes in ICD-10 to complications of a foreign object accidentally left in the body following a procedure. In ICD-9, there's only one code for that. So imagine what's going to happen if you don't have a process in place or ask this question at this time or in the next year about your coding process and the exceptions that you might incur. I can show you ways that we can help you with that, with automation of that workflow. So speaking of workflow, why with today's technologies do we wait on things, inter-office envelopes, push carts, and committee meetings? There's so much technology out there that can automate that can make it happen in real time, automate the paper even, and help you work so much more efficiently. And that's what we're really here to talk about, is the processes, elimination of a lot of the work that's being done, the redundancy of the data that you need to enter into documents and things like that. And how exactly what's the step is to come up with questions of why. Why is it that we're tasking people with keying information that has been collected into the form? Why do we duplicate paper and electronic records? Why do we buy and inventory and distribute pre-printed forms? And why do we spend time putting adhesive labels on forms? And I'm sure that you can look at your processes and find a lot of more questions to ask about and for improvement. Where is the waste? Well, there is waste, and Mark pointed out some of the same issues. I'm going to go through a few more that are more specific to what FormFast can affect and help you get around here. The effects of poorly designed forms, overproduction. You don't really consider any of a pre-printed form to be overproduction because just in time. You need on demand. You don't need to produce something and sit in an inventory that's going to go obsolete possibly. That obsolescence says patient safety issues. If it's on a document or something is not on a document, and somebody grabs an old version of that document, you know it's going to cause an issue with patient safety probably down the road. There's a lot of waste that have a lot of impact in your organization. One of the biggest impacts, too, what we saw with one of my first slides was the staff time. Your potential. Mark talked about highly paid and educated staff that was putting caps on bottles. It's the same. Ask your staff to key information into computers that was already collected on forms, or spend time tracking down paperwork that's already in process, rather than looking at a computer screen and seeing where that process is at. Where does FormFast fit in and how do we help? This is our model for document automation adoption at hospitals. The point here is that you're in one of these three stages in your hospital today. At the pyramid, you have pre-printed forms, or paper forms, little automation, maybe you're stamping or using adhesive labels to place information on forms. Level up in the pyramid, you may have forms in place, you may have some automation, maybe admissions, maybe a few more. You have a little bit around forms and print methods and e-signature. And then the top of that pyramid, you're really leveraging everything that you've got below that to go with business process improvement, electronic document workflow technology. So at that first level, what FormFast helps you do is eliminate those pre-printed forms. Eliminate inventory, that risk of grabbing the wrong type of form, the wrong version of the form, the distribution cost, the production cost, the storage cost, and the obsolescence of those forms. And then allow you to dynamically barcode those forms, barcode your wristband so that you have a single system across your hospital coding that ties in with your pharmacies, with patient identification, medications, blood drawing, and everything else. And of course, at this stage, we're helping you convert your paper forms to eForms, to make it very easy for you to get into this new method of working with electronic forms. The next stage, of course, is taking that to the next level of electronic forms from giving you print forms on demand, giving your staff the ability to select forms from a website and print those with patient information on them quickly. Business rules-driven output. So based on information that's input into your system, only forms will be put at the right time in the right place. And collection of e-signatures is a big one at this level too. Being able to leverage this technology and the automation in forms that you have to use electronic signature capture devices rather than printing just the forms that need to be signed and then scanning those back into the system. And at the top of the pyramid, the pinnacle is able to leverage even further now the electronic forms and technology to create forms, map it, and add people to the processes using electronic workflow management systems. So now electronic document workflow that can automate the routing allow people to collaborate on documents, integrate fully with your EMR system. So when users are in the EMR system, rather than going to an system, they can go from EMR system past context over to your automation system, launch it directly. Apply this technology to your non-clinical projects as well. So you can apply this to your revenue cycle, apply this to your HR, inside and outside of your clinical processes. FormFast provides the tools that will get you there. So surrounded by the people and the knowledge and the services, leverage these tools and help you leverage these tools are three main core sets: print, eForms, and workflow. Print really happens in the background. The users don't see, but it's a huge improvement at your organization. So there is FormFast will select streams that go through your organization, write rules across, based on that print stream, and then print forms where they need to be printed, and proper forms, the proper formats, more data. So for example, if you admit a patient who's under 18, the print system would indicate that print stream and automatically produce the parental consent forms that are necessary. Same is true with Medicare paperwork and things like that. That are rules that need to be printed automatically. eForms on demand is another level, taking that type of technology, rules-driven printing, but giving it an interface so that documents, if you need reprints, if you need papers with data on them, you go to the website, click on the form you need, select the patient names that you're dealing with, and then click packets or groups of forms logically on them rather than having them sitting there in a bowl that you have to go and print or stamp or put a label on. There's more than what in the graphics box. You merge any data you've already collected, which will reduce the redundancy and the time spent filling out forms. And then the workflow automation to take forms or processes, create new processes or improve those processes, and drive those through an automated system so that taking a form, maybe a checklist, it may be dealing with another document, and that form out through different participants, collect signatures, and then send it to your final disposition archive or other activities off of that. What does it look like with FormFast and workflow? So we apply these technologies, and we help you to apply techniques of improving your processes. And this is come out the other end with. You're going to reduce the time spent completing forms and routing requests, tracking processes that are currently in the system or your currently untamed processes. We can help you manage those. You can automate any paper-based process that you have in your system today that may not be necessary. It could be if it's operating in real time through an automated system. And you can apply those same techniques to evaluate other processes and create those into an automated system and help you with that. The big things is we're putting this process together, and we're a lot of the motion involved, a lot of the, putting that form in an envelope and putting it in a cart and pushing it through the hospital. So you're eliminating the waiting and you're getting an instant routing and delivery. But the form, if you're working on a paper form, that's a real silo of information. It's not going anywhere. It's only in and of itself. You put this in automated systems, you get the ability to collect that information and analyze that information. You get the ability to collect the information about form and document usage. So you can analyze and improve both your processes and performance metrics based on those two types of information collection. And streamline your interdepartmental processes with the same amazingly powerful tool. You can apply techniques and these technologies across both clinical and non-clinical departments. A big statement about amazingly powerful workflow tool. I'm excited about being able to help hospitals. And what we've done in hospitals is we've given them a very easy way to create a new application. Create of information and coming up with an end result. And really steps to it. You can start with a form, or you can start with a blank slate. We help you either way. What you have into that form, you already know user data, maybe you already know patient information. You add that to the form. Define the routes that it's going to go through. You define the steps that need to take place on those route steps, such as signatures or attachments. For the people that are in this role, and the actions, what are your outcomes? What do you want? Do you want reports off of this? Do you want approvals? Do you want emails? Do you want this to go to an archive? That's how simple it is. And this is an amazingly powerful tool to apply to your workflows. Packages this in a couple of ways. You can do this is apply this specifically to areas, and these areas are just examples. You may have other areas that you would apply to. Take this technology and apply it to maybe your compliance area with RAC audits or policies and procedures documents. Or apply it to clinical, or you can apply it to human resources. You can pick one of those, apply a predetermined or predefined application to that. Or you can take the package as a tool set, apply it across the organization for those high-level needs that you do have, regardless of what area it's in. Just some examples of what we're doing in these different areas are the revenue cycle integrity. A big area here is the RAC audits. Of course, that's a very intense process, tight timelines, requirements. We're going to automate that, give you dashboards, give you the reports you need to manage that effectively and efficiently. Charge maintenance is another area that can manage and maintain through an automated process. There are even small things like late charge entry that aren't addressed maybe by your core processes. I mentioned that in the beginning about the coding. So if you don't have a coding process in place now that's really efficient and working well for you, we have processes that can help. We have models of how that can work for you better, and of course, part of the process is to sit down with you to determine the original starting point and see if we can make that better. Using the clinical experience, doing with admissions document print management, automating things like your ordering for physicians in clinics, being able to order online physicians when the CPOE system may be down or unavailable, or maybe some type of exception to that. Compliance, again, this touches on so many areas. Physician credentialing, incident reporting, their approval process. We're a formation organization here. Most hospitals will have a forms committee. There's a process around getting those documents approved. We can do that as well. Supply chain optimization. Your request forms. Mark talked about a purchase request form. Being able to take that purchase request, make it automated, eliminate the steps that don't need to be there, make everything occur in real time. It's a very large area. It's a lot of paperwork, and it also requires a lot of documentation to be cleaned. Immunization records, licensure, all of that information can be automated. Your first aid form set that you take when you're the orientation checklist, all of that. There's a lot of opportunity in the human resources area. It goes into the administrative excellence, just the rest of the running of your business, your AP invoicing, your checks and payroll, mail escalation processes, report management, and distribution. All of that can be managed through our set of tools. And make sure the physicians are set with what's happening. We want to make their lives easier, so we can integrate with speech recognition tools. We can help you make the credentialing process easier. Integrate your communications inside and outside of your hospital and across departments. For of the I just talked about, you can stop by our website at formfast.com. Link here up on the top. Click. You'll get a lot of solutions and short 3-minute videos on each of those that will help you get an idea of how we affect those areas. It's a very good resource for you to do the next step with. Down into what do we do next? You know, there's the Lean about 5 S's. One of the things you do is the 5 S's on your project. You know, you've asked why, you've identified what it is that you want to change, you've made a problem statement and what your end goal is, and then you start doing a 5S. And here's some of the things you can do around documents: the sort, so you're getting obsolescent forms, maybe consolidating some forms, but maybe taking that number of 5 forms at admissions down to maybe 9 or 10. That would be a way to start. Straighten, make all forms available on the web, whether they're blank or merged with patient data. So that's one of the first things you want to be able to do. Merge that with patient data or employee data if it's outside of your clinical documents. And then review your documents and make sure that they are working in the document workflow, that where they're filled out meets the way they're laid out. If somebody doesn't have to search through the forms, know where information's at. And that goes to standardizing. Make sure that you standardize your forms, and then also monitor what you've done in the first 3 steps and improve as you go forward. Also part of the sustaining is review your document workflow and define the time periods that you want to do this review, and put that in place so that you're always continually improving and continuing your process improvements. Beyond this, I know we're running out of time. I want to hear your thoughts. So we've got the question and answer period coming up right after this. Go ahead and enter questions into the Q&A section on the right. We're having a follow-up webinar on February 15th. You can write that through our website, or you'll be redirected there after this. Also, after this, after you leave here, there'll be a survey that comes up with a few quick questions. We want to get some feedback from everybody on the call. I'm going to open it up to question and answer period, and again, thank you for your time.
Thanks very much. We appreciate your insight today. We're going to go ahead and start off with a few questions. The first one, the generic question that came in: are copies of these slides available to the participants? And say, well, we're going to follow up in a day or two with a copy of slides for everyone, along with a recorded copy of today's webinar. The first I'm going to send out over to Mark is, could you please mention again what hospital has 0 medication reconciliation error rates?
It was the ThedaCare system in Wisconsin. That was in their Lean-based collaborative care unit.
What is door-to-balloon time?
It's basically elapsed time from when a patient arrives, let's say emergency room, if they're potentially going to be sent to the cardiac cath lab, that time to the point where they actually receive that care, have the blockage cleared with the quote-unquote balloon in the cath lab.
Excellent.
It's a colloquial term for a very serious process.
Okay, great. This question is going to go over to Sean. Sean, will these eForms integrate with an EMR like Epic?
We have the base of our products is built on an integration platform as well. We have integration built into our product that allows us to integrate with virtually every other product out there. So we do have customers that use it on a variety of EMR systems and launching from those systems, or feeding those systems with data, or pulling data from those systems. So yes, it will.
Okay. And another question for you, Sean. This is interesting. Are paper forms necessarily bad? the attendee says, I think it all comes down to workflow, not whether or not it's electronic or not. If having a piece of paper in my hand makes me feel more accurate and less wasteful overall, I will use a paper form. What would be your answer to that?
That's right, too. And we do printing. Don't get me wrong. We do a lot of printing, and print forms are necessary. There are a lot of checklists that need to be printed and posted. Maybe there are a lot of forms that are just better off printed, like you say. What we want to do is leverage the rest of the systems in the organization. So if you've already collected data, we want to fill out as much data on that form before you even print it, so that when you do have it in your hand, you're not spending time looking things up and put words into the form. We want to eliminate the opportunities for human error, automate as much as we can before that comes out of the printer. We don't really want to say that everything is going to be printed or nothing's going to be printed. We understand that is the reality. Some things are going to have to be printed, and we want to make sure that we're doing it just smartly.
Great, thank you. The next question goes over to Mark. What are the initial stages to kick off Lean implementation in a hospital, both on the clinical side and at the back-end office?
Well, we see a lot of variation out how hospitals are approaching it. It's often easier to describe what Lean looks like than it is to describe how you get there from here. A lot of organizations, I think that, well, let me just talk about maybe I think the preferred approach. My preferred approach would be small. One value stream, or to start with one and the value stream that it's part of. So, for example, a lot of hospitals have started in a hospital lab, where they've, looking at the flow of specimens. They start with emergency department patient flow. Start small, train people within the department. Maybe start with a project team to help kickstart things, to do design and improvements within the department, and have others focusing on lean practices as they go. So to start with what project, well, we're going to train everybody in the hospital, have everybody work in parallel. I think it's far more practical. Try to just start small, demonstrate proof of concept, focus on trying to create, a quote-unquote culture within that department, and then use that as a line model department for the rest of the hospital. One other thing I'll mention, a lot of hospitals use week-long improvement events, whether they call them rapid improvement events. Those can be helpful, but the cautionary tale, I think it's to say that doing 100 Kaizen events, doing 100 week-long events doesn't magically make you lean. That a lot of week-long events, if they're done, focusing on the day-to-day lean management practices, a lot of those week-long events tend to really and attainment rate with the week-long events can be quite poor, which can be frustrating. It's a form-based, I guess, to make improvement that doesn't stick. So that week event approach is very popular, but I think there's a lot of examples where people are that there's going to be different approaches involved beyond just doing those week-long projects.
Great, thank you. One last question, and since we're kind of running short on time here, any of the questions that we don't get to today, we will follow up with a personal email or call to you and follow up with you. The last question is for Sean. Does the system integrate with Meditech Zincs order sets, or would you order sets replace Zincs?
Well, we've done development work around Meditech, and we work with them to make sure the system is in sync with theirs. The order sets, we can put the automation tool behind that and the publication tool behind that. Zincs and places like Wolters Kluwer's Provation are great content providers that really stay on top of the content that you need in those order sets. But we can work with that content and provide distribution and automation behind that.
Great. Thank you very much, both Mark and Sean, today for such terrific information. Once we receive the final attendee list from WebEx, we will send you a pedometer as our way of thanking you for attending today. Our web series continues next month on Tuesday, February 15th at 11 a.m. Central Standard Time with a 5-minute demonstration on our FastFlow solutions. As you learn, FastFlow is a key asset to enable hospitals to embrace significant process improvements, increase quality, and help you become a high-performance hospital. You can register for this webinar at www.formfast.com/web-demo. Please update on all of our activities and news by following us on Twitter, Facebook, and LinkedIn. We'll also be in Orlando at the HIMSS 2011 show from February 21st through 23rd. Please stop at booth number 463 and learn more about FormFast and the Untitled Workflow Premier. As you're leaving the meeting today, there will be a brief survey to let us know how you currently use or plan to implement Lean Healthcare. Please take time to fill that out. And if you have any questions or would like to contact FormFast, please call us 1-800-218-3512 or visit our website at www.formfast.com. We appreciate you taking the past hour to learn more about FormFast and Lean Healthcare with Mark Graban. Thanks and have a great afternoon.